Thank you very much for your kind introduction. I've been asked to talk about epidemiology today. And there's a diagnostic test to tell an epidemiologist apart from a non-epidemiologist, and that's whether you're able to pronounce the word epidemiology correctly. So, okay, air quality and health. This is supposed to work. This way. I've been given 4 different, as I call it, charge questions to talk about milestones and current findings. Talk about mortality, but also cardiovascular, respiratory, and systemic morbidity. Talk about causality, cohorts, Clean Air Acts, and about heterogeneity of effect estimates. That's a lot of different topics, and I'll try to get through it in a reasonable amount of time. I'll start with milestones and current findings, and I move to cohorts there because I think that's where it belongs and not so much in the topic of causality. I'll talk about mortality and cardiovascular, respiratory, systemic morbidity as well. But I'll start with a major milestone, the London 1952 smog. And as you probably all know, there was a large increase in soot, smoke, and sulfur dioxide, and a large increase in death rates. And I think that this is one of the associations, if you wish, where causality is not an issue. Everybody accepts that this is a causal relationship between the smog episode in December 1952 and the mortality. And if you do some calculations on the back of an envelope, this smoke inhalation in the 1952 smog, which again everybody accepts as a causal relationship, is equivalent to smoking 1 to 2 cigarettes a day for 5 days. And I think this by itself, starting from a causal relationship between outdoor air pollution and mortality, which is not debatable, I think, in this example, just shows that, you know, direct comparisons between smoking and air pollution make no sense. There's a lot of qualifications there, a lot of things that you need to take into account. You just can't make the simple argument that based on the mass contribution alone to the inhalation, you can compare these things, because this shows that that doesn't work. One of the questions asked about the London smog episode was always, did this kill folks who were almost dead already? That's called harvesting. If you hasten the death by just a few days or a few weeks, then the public health importance may be less than when it's a longer time period. But if you have a big increase in death rate among people who are almost dead already, you should have a big decrease in death rate in the weeks after that. As you can see from this graph, which extends into March of 1953, there's no such thing as actually a prolonged period of increased death rates compared to the death rate in December before the smog episode hit. And a question that has always been raised is was this perhaps a flu epidemic? The 1954 report on this actually argues that most of the mortality in the winter of 1953 was due to the flu. But the later analysis has looked at that, and you know the data that you have available for that period are not all that solid, I should argue. But this reanalysis published in 2002 argued that actually most of the deaths, unexpected deaths, were not related to influenza deaths, but to other causes and possibly the late effects of the air pollution episode. That's a milestone in our field. Do we have similar episodes still? We have them. And a unique example, I think, is the episode that hit Moscow in the summer of 2010, a combination of a heat wave and wildfires which were raging for long periods of time, all over Russia basically, not just near Moscow. And this is a graph from the paper that came out on that, showing that there was a heat wave, a long heat wave, which increased mortality, the black line. But then there was a period of wildfires, a shorter period, which increased PM10 concentrations to 500-600 micrograms per meter cube at the highest levels. You can see that in association with that episode of wildfire smoke, the death rate shot up again, and you know, you're looking at a threefold increase in death rate compared to the baseline which you would normally expect. So almost the same magnitude as the London smog of 1952, but now related to a combination of a heat wave and wildfire smoke. So a very different situation, but a picture which more or less looks like the one that I showed from the London 52 smog. When it comes to short-term effects, for a long time we've been doing time series analyses now, looking at the day-to-day variation in air pollution, day-to-day variation in mortality or morbidity endpoints. There's hundreds of these studies, and one of the most recent ones combines the data from 652 cities in the world. Shows you how extensive this database is. It was Haydon Kahn, a senior author, came out just a few months ago in the New England Journal of Medicine. And you can see that there's now a lot of work going on in China. So there's lots of data from hundreds of Chinese cities that have done time series studies on air pollution and mortality. And if you put it all together, this is what it looks like. Starting from very low concentrations, close to zero, monotonous increase in mortality with a diminishing slope at the higher levels of concentrations. And the WHO air quality guideline, the short-term guideline for PM2.5 is 25. You can see a lot of this is going on below those levels. And there's some interim targets from WHO, the Chinese air quality standard right here. And you can see that with very narrow confidence limits, because of the large numbers of cities, large numbers of data that were included in this analysis, there's a monotonous increase in mortality related to PM2.5 concentrations on a day-to-day basis. And this sort of is a combination of many studies that have been conducted in the last 30 years or so, ever since Joel and some other folks started this line of work in the early 1990s or late 1980s. Move to cohort studies. The cohort study is the cohort is a Roman invention. The army was separated in groups of 480 soldiers. You could measure the success in battle of the cohort by simply counting how many folks got killed or wounded. So a successful cohort had few casualties, a non-successful cohort had many casualties. We're still using the same principle in our cohort studies. We assemble cohorts, send them out into the battle of life, and come back 10 or 15 years later and count who's left. That's the basic idea. Focus is not on temporal so much, but on spatial variation in air pollution. Course followed for years. We collect detailed data on personal habits such as smoking, occupation, diet, and the data more powerful than those that you find in administrative databases that we use, for example, for the time series studies. But they're expensive studies. Analysis techniques focus on differences in survival in relation to air pollution exposure and other determinants of health. The key study here is really the Harvard Six City study, first published in 1993, so a long time ago, by Doug Dockery and colleagues. And the 6 cities are located here. There's two clean cities, Portage and Topeka, two moderate pollution cities, St. Louis and Steubenville, and some high polluted cities. Now the moderate polluted cities are Watertown and Kingston, sorry. The high polluted cities are St. Louis and Missouri. And then when they did the analysis over a 15-year period of time, this is what the survival curves look like. So you start with 100% alive. And after 15 years, you see that survival curves coming apart. There's less survival in some locations than in other locations. And then the question, of course, is this air pollution or is this something else? So you need to control for as many potential confounders as possible in the analysis, which the investigators did to the best of their ability. And this is what came out. An almost linear relationship between fine particles, which were already measured in that study starting in the 1970s, a really unique effort at that time, more or less linear relationship between fine particles on the x-axis and the rate ratio of total mortality on the y-axis. Steubenville here, Portage and Topeka here. And the range is important to look at because it's about 10 to about 30 micrograms per meter cube, and the limit value in Europe is still 25. So, and this is a publication from 1993. This is going back a long time. What have we done in Europe? The ESCAPE study was already mentioned briefly in the beginning as showing some negative findings actually for some of the endpoints that we looked at. This is a concentrated effort that we coordinated in Utrecht to look at long-term effects of air pollution, and not just mortality, but a range of morbidity endpoints as well, which is important, I think, to understand. And the basic idea was to collect existing cohorts. There was no money, of course, to start a lot of new cohorts, but there's cohort studies going on for various reasons all over Europe for a long time already. Birth and pregnancy outcomes, respiratory morbidity, cardiovascular morbidity, cancer and mortality. The essence was to standardize the exposure assignment. So we had particulate matter and NOx monitoring and modeling in 20/36 EU areas. We couldn't do PM everywhere for financial reasons, but we chose the most densely populated parts to do that. And this is the spread over Europe of the different centers that participated, so really a Europe-wide effort. We planned the study to focus on some 20 different endpoints, and they are listed in this cartoon, really cradle to grave, starting from birth weight. There are a lot of morbidity endpoints in childhood and adulthood in between, and then non-accidental mortality, cardiovascular respiratory mortality at the very end. I can't show you all of the results. I'm just showing you one example, and that's the one that we did on low birth weight. The ESCAPE study paper, first authored by Marie Petersen from Denmark, came out in the Lancet Respiratory Medicine in 2013. And we found that all the air pollutants had a positive association, some significant with term low birth weight, and birth head circumference was negatively associated with all the pollution metrics that we used. And this was a combination of some 15 different birth cohorts across Europe. With a concentrated effort to do the analyses everywhere in exactly the same way. What's ongoing at the current time is looking at the question, what happens at very low levels of concentrations. We realize we have the PM 2.5 air quality guideline of 10 micrograms per meter cube, issued by WHO in 2005, currently being revised. That was based on the evidence which existed in 2005 and before. And what's happened after that is that a lot of work has gone on to more comprehensively model and monitor PM concentrations across the world, making use of chemical transport models, satellite observations, ground level measurements, etc. And several of these studies, especially from Canada, but also from the United States, are now suggesting that these associations between PM 2.5 and mortality and some morbidity endpoints extend to well below the air quality guideline of the WHO. And the Health Facts Institute is currently funding 3 studies, one in Canada with Mike Brouwer, one in the United States with Francesca Dominici, in which Jill Schwartz is also heavily involved, and one coordinated by us in the Netherlands, looking at millions of subjects across these continents to find out what's going on. And we now are more actively including also folks living in rural areas, which was not the case in earlier studies back in up until 2005, 2010 or so. So that's new. As you can see, the average PM 2.5 levels are still about 15 micrograms per meter cube in Europe, 11 in the US, and only 7 in Canada. That's the average. So this is really very low concentrations. Some preliminary findings published already from the Canadian study are shown here, looking at the census and health cohort. And you can see that the association is found essentially starting from 0. Canada has some areas with extremely low PM concentrations. Some results from the Harvard study. You can also see that effect starting, the association starts at about 5 micrograms per meter cube. You don't get to these near 0 levels in the United States because it's more densely populated and more surrounded by other polluting countries, but also levels that extend well below the air quality guideline of the World Health Organization. The European study is looking at low levels effects of air pollution in Europe. We have a bunch of cohorts which originate from the ESCAPE study that we followed further. We also have some 7 administrative databases like the ones in Canada and the US, where we're looking at complete populations of the Netherlands, Norway, Denmark, Belgium, etc. This is all still very much work in progress, so I can only show you a few first results of that. The Cox-pooled models of the pooled cohort, so these are essentially the ESCAPE cohorts, again show positive associations between PM 2.5 as well as NO2 and black carbon for natural cause mortality, but now also for cardiovascular disease mortality. As you noticed in the beginning of the day, one of the ESCAPE studies which did not show associations with cardiovascular disease mortality was quoted. There's some reasons why we do see these associations now, and we did not see them in the previous analysis, which you can go into in the discussion if you want to. Interesting is also that we see protective associations with ozone. We're modeling ozone on the 100 by 100 meter scale, which is very different from the modeling in the United States and Canada. We're still struggling to find out what exactly is going on with our ozone models. After adjustment for ozone, the associations with the other components essentially remain, so it doesn't explain these positive associations with the other main components. This is ongoing work. And this is, for the pooled cohort, an image of the concentration response function. And as in some previous graphs, you can see that, with widening confidence intervals, with small numbers of observations, the association definitely exists well below 10 micrograms per meter cube, which is this line, which is the air quality guideline of WHO, and up here the 25 micrograms per meter cube guideline as a limit value of the European Union, which I think we all agree is not being protective. So this is work in progress, of which you will hear a lot more in the next 1 or 2 years, I'm sure. Systemic effects. This is an example from a study from Germany that has estimated exposure to PM2.5 specifically from traffic, PM2.5 specifically from industry, and has linked that in the Heinz-Nickdorf recall study to measures of CRP as a metric of systemic inflammation. And for both PM2.5 from traffic and PM2.5 from industry, the investigators found a positive association with CRP, which was more or less the same in men and women, and which was also more or less the same in the elderly and the less elderly folks in this cohort. There's of course more details in the paper, but this is just one example of an intermediate metric, CRP, a measure of inflammation that might explain some of the morbidity associations with PM2.5. This is also very recently published work looking at emphysema and lung function in the MESA-AIR cohort, a well-known study from the United States. It has found associations between long-term exposure to air pollution and change in emphysema and lung function. And you can see that for ozone as well as NO2, as well as for black carbon, the association was there. For PM2.5, the association was there cross-sectionally, but not prospectively. This is a recent finding looking at a morbidity endpoint, which is clearly an important one. In terms of the kind of morbidity endpoints that we are now seeing being associated with air pollution, this is a figure coming from a recent ERS ATS policy statement. George Thurston is the first author that lists all the factors, all the endpoints that have been associated with air pollution in recent studies. The bold ones are the ones that are being quantified by the Global Burden of Disease Project. So where the Global Burden of Disease Project sees enough evidence for causality of the associations to actually quantify the burden of disease related to these endpoints in relation to air pollution. So there's a lot more than just mortality. There's a whole range of different morbidity endpoints that are now seen by the Global Burden of Disease activity as being sufficiently causally related to air pollution to do actual quantification of the burden. And Francesco Forestiera later today will tell you more about how these burden calculations proceed. The hot potato, causal inference in epidemiology. As you all know, we produce associations, sometimes called correlations in epidemiology. We cannot experiment very well in epidemiology. If you would ask me personally, I would love to ask half of you to go to the South Pole for the next 10 years to breathe incredibly clean air, and would ask the other half of you to go to New Delhi for the next 10 years and breathe dirty air, and then count how many of you are still alive 10 years from now. But you won't agree to that, even if I pay you to. And there would be, of course, all sorts of regulations that would forbid me to even try to make a protocol like that. But so in principle, experimentation is possible, but in practice, it's difficult, if next to impossible. So how do we arrive at causal inference from epidemiology? And I would, I still mirror to read this paper, 1965, the Environment and Disease Association or Causation from Bradford Hill. You can find it on the internet easily. So a number of considerations that he mentions: temporality, which is probably only hard consideration. If the cause does not precede the effect, it's kind of hard to think this is causal. Not easy to ascertain when it comes to diseases with long latency periods, for example. Consistency, the finding is repeatable. You would like to see it not once, but twice, or 3 or 10 times, or 100 times when it comes to the time series studies. It's like coherence with animal experiments. The coherence with a mechanism that explains the associations is always very important, and that's where a lot of collaborations with toxicologists have come up in the last 25 years. Biological gradient would be nice if there's a dose-response relationship, if it doesn't bounce all over the place, these associations, but you see a nice dose-response relationship that would support causality, but never proves it in absolute terms. It's considerations, and it's not a set of hard guidelines or criteria that you can simply check off in a checklist kind of fashion. A rather similar framework is being used by EPA to look at causality of air pollution-related health effects for reviews of the National Ambient Air Quality Standards. This paper came out some 2 years ago, so that's more recent. You will find a lot of the same thinking in that paper as you find in the earlier Bradford Hill paper. And what we see in the last several years is a lot of activity related to causal modeling, so that's a somewhat different way of analyzing your data in epidemiology, and Joel will actually, after the break, talk about causal modeling and what that brings, what it adds to the considerations to talk about causality. Just very quickly for your reference, I'm not going to read these out in details. The latest PM Integrated Science Assessment draft still has identified a lot of causal or likely causal relationships between PM 2.5 and a series of mortality and morbidity endpoints. So that's the end result of a long assessment as written up in this integrated science assessment. For NO2, the causal relationship is only seen for respiratory effects short-term, and likely causal relationship is respiratory effects long-term. But there the yellows are in the minority, as you see. EPA has focused very much on NO2 itself, so does not consider NO2 as a marker for a mixture, which is what we like to do, which we tend to do in Europe more. So that's important to keep in mind. This is about the evidence for NO2 itself and nothing but NO2. So that's important to keep in mind, also from a practical point of view. For ozone, a few more. This is a somewhat older integrated science assessment currently being revised. Somewhat more yellows of causal relationships and likely causal. And causal and likely causal is seen by many as sufficient evidence to actually do something about it. If it gets less than likely causal, you would have more hesitations to actually propose policy measures, but causal and likely causal is sort of sufficient to say, okay, this is enough to worry about it. How do we experiment? We don't experiment in environmental epidemiology, but there's lots of natural experiments, things that go on in society anyway, which we then with some clever analysis can take advantage of. And this is a very recent paper I came across, a discussion paper, so it hasn't been completely peer-reviewed or accepted yet, and it's called The Impact, this must be interesting to you guys in Germany, The Impact of Car Pollution on Infant and Child Health, Evidence from Emission Cheating. Paper from economists, so not epidemiologists. The link is here so you can find it yourself. This is non-cheating diesel cars in 2007. There was diesel cars in 2007, but the cheating devices had not been introduced yet. So cheating diesels in 2007 did not exist. Non-cheating diesel cars 2015, and then the map of the United States is filled with, about 500,000 cheating diesel cars. The clean Volkswagens especially were those. So they've been introduced since 2007. They weren't there, and they were there in 2015. And the study actually tried to figure out what happens in these areas where you have these introduced in a higher fraction than in a lower fraction. What does it do to air pollution, and what does it do to things like asthma and low birth weight? I'm only showing some results of birth weight. You can see a very close association between the fraction of cheating diesel cars per 1,000 with birth weight, and a positive association with low birth weight. And as a control condition, cheating gas cars between quotation marks, it's the same kind of brand, but then gas cars. And you can see there's basically no association with birth weight and low birth weight for the gas cars, which were used as a control condition for the the cheating diesel cars. So this is an interesting approach, I think. Again, it's being discussed at the moment, not accepted yet, but an interesting approach to look at a change in the environment and what it might do to a change in health conditions like birth weight in this particular case. Another example, the Beijing 2008 Olympics were a huge atmospheric science, atmospheric chemistry experiment. They did a lot of efforts to reduce pollution during the 2008 Olympics. And you know, despite all the efforts, you can see the day-to-day variation, which is always there, was still there during the Olympics. But you had some very clean days, relatively clean days, and some more polluted days. You can actually see when you look at the visibility of these pictures. But this is black carbon and PM2.5. You can see a lot of variation from day to day in control periods and then much lower concentrations during the Olympics. And then exhaled NO as a marker of airway inflammation in children was also clearly decreased during the Olympics period compared to control periods. There's a lot of variation again from day to day. So this is one example of, again, a huge experiment that the Chinese were able to pull off with a lot of effort, and which you can actually use to make some, I would argue, causal inferences about what the changes in air pollution do to you, changes in biological endpoints. There's a lot of other endpoints that we looked at, which I won't get into the detail of. Another one, the Clean Air Act in the United States has reduced particle pollution massively in most areas. And this is a graph showing from a 2009 paper from Arden Pope, showing life expectancy in relationship cross-sectionally to PM2.5 in the 1979-1983 period. Sort of negative association between PM2.5 and life expectancy. There's a lot of scatter, as you might expect from data like this. And this is looking at the change in PM2.5, a reduction. So the higher the number here is, the more reduction in PM2.5 is achieved over a 20-year period, and the change in life expectancy. And Arden and its colleagues try to control for as many potential confounders as possible. You still get a lot of scatter, as you can see. But there was a, I would argue, reasonably convincing association between change in PM2.5 over a 20-year period and change in life expectancy. So this is another way to take advantage of changes in society which take place anyway, and which you can try to link to changes in a health endpoint. This is a very different scale. This is looking at one street, a study we did in the Netherlands with Hannah Bogaert as part of her PhD work. So this was looking at reduction of traffic in a very busy street in The Hague by about 50%. What did I do to PM10, PM2.5, soot and NO2? What was the control situation? Because there's, there's secular changes in pollution concentrations for other reasons, so you need to have a control location. You can see that especially for PM2.5 and soot and NO2, the control location was some reduction, but by far not as much as in the busy street, which had a reduced traffic flow. And this was what happened to spirometry in a bunch of 70 people on that street, which we investigated before and after the metrics. You can see that there was actually an increase, a small increase in FVC and FEV1 in these folks. Normally with age you expect a decrease, but apparently our interpretation of these results is that their lung function was chronically depressed because of the high air pollution exposures that they were experiencing on a day-to-day basis before the traffic measures were taken, and there was some rebound after the measures were taken. This is focusing on a single street. So you can do this on a single street, you can do this in the whole United States. You have all sorts of different time scales and spatial scales where you can try to take advantage of changes which are happening in the environment, which then sort of support our estimates of causality. The Burns review was quoted earlier today as well, suggesting that the Cochrane review didn't see much coherent evidence of that these various measures, of which I've given some examples, actually showing much of an effect. I think what these examples also show that there's huge heterogeneity. There's one Olympic experiment, there aren't two or three, which is of course kind of hard to do. There's a couple of these kind of street experiments that do not always show the same thing, so there's heterogeneity in these findings, and that's what a Cochrane review typically picks up. There's heterogeneity, so it's kind of difficult to come to one general central conclusion from these metrics. Heterogeneity, finally, refers to differences in effect estimates obtained in different studies. And in air pollution epidemiology, heterogeneity is the rule, not the exception. We study different situations, we try to get repeatability, but the repeatability is never complete. We see heterogeneity, and that's the way it is. And the question is, can we explain that heterogeneity? There have been many documented reasons for heterogeneity: differences in diet, socioeconomic status, age, sex, pollution level, co-pollutants, pollution sources, prevalence of air conditioning, etc., etc. These are all documented in various settings in the air pollution world as reasons for heterogeneity. Now, if you pull together, as we are doing right now for the WHO, the systematic reviews of associations between, for example, PM2.5 and mortality, it's not usually possible to address all of these reasons, documented reasons for heterogeneity in a formal meta regression, because not all studies measure these things. So when you try to address this in a formal meta-analysis, in a formal systematic review, directly, you sort of end up empty-handed because the data are not there in each and all of the studies for which you would like it available, despite the fact that there's many documented reasons for heterogeneity. So that's something that we're struggling. I need to finish. I will. Something that we're struggling with in the WHO process, for example, and how exactly to address heterogeneity and how to value that in terms of the certainty of the evidence. One example of heterogeneity, this comes from the huge paper that came out in the New England Journal a few months ago. You can see that the effect estimate from 272 cities in China is a lot less than from the other areas, which are essentially all highly developed countries, lots of different cities included. The overall effect estimate is actually driven more by the Chinese effect estimate than the other effect estimates. And what you remember from the graph is that it was really leveling off at high concentration. So in China, you expect a smaller effect estimate per 10 microgram per meter cube. That should never be taken, should not be taken as something that you can derive a worldwide average effect estimate in a linear fashion from. This heterogeneity is real. You need to take it into account when you do impact assessments. This is just an example of where you can clearly see that there is heterogeneity, that there's a reason for it, and that you better take this into account when you further interpret these findings. Last slide, all scientific work is incomplete, referring back to Bradford Hill, 1965 again, whether observational or experimental. Experimental evidence is never complete as well. So it's not confer upon us the freedom to ignore the knowledge we already have or to postpone the action that it appears to demand at a given time. Who knows, asked Robert Browning, but the world may end tonight. True, but on available evidence, most of us make ready to commute to on the 8:30 the next day. Thank you.